Now, this is an illustration of various types of morphologically abnormal lymph nodes and how we would deal with them. In the center is a normal appearing lymph node with fairly symmetrical hypoechoic cortex and a normal appearing echogenic mediastinum or hilum. In the first example here, we have symmetrical cortical thickening. Notice that I've put a white outline around this image. And the white outline illustrates to me that this is a non-specific lymph node. This could be a reactive node, or it could be a node containing a lot of metastasis that's so extensive it's caused symmetrical cortical thickening. I need to go to my first tiebreaker, and that first tiebreaker is going to be, what does the adjacent lymph node look like? The next two lymph nodes show asymmetric cortical thickening. I've put a little red outline or a pink outline around this, indicating that this is high risk. This is the hallmark for metastatic disease. This is metastasis till proven otherwise. I don't need another tiebreaker. I don't need color Doppler. I don't need pulse Doppler. I don't need to look at the opposite axilla. I need to biopsy these lymph nodes, and I specifically need to target my biopsy to the portions of the cortex that are abnormally thickened. The next case illustrates rat bite indentations of the mediastinum. This again has a pink line around the outside because it strongly favors metastasis over a reactive lymph node. In association with the rat bite indentations is eccentric cortical thickening. So again, this is metastasis until proven otherwise. I want to biopsy this lymph node, and I want to specifically target my biopsy to this portion of the cortex. I don't want to biopsy the thin part of the cortex because I might get a false negative. These are two examples of flattening and compression of the mediastinum, which is also another way of saying that we have symmetrical cortical thickening of a more severe degree. Even though the symmetrical cortical thickening is of a more severe degree, this is nonspecific. These lymph nodes may well be reactive rather than metastatic. This is where I want to go to my tiebreaker again, and again, the key tiebreaker I want to use first is to compare to adjacent lymph nodes. This is an example of displacement of the hilum to the side of the lymph node. This really is the same as eccentrical cortical thickening. I've put pink around the box indicating that this is a high-risk lymph node for metastasis. And once again, I don't need a tiebreaker. I don't need color Doppler or pulse Doppler. I just need to biopsy this lymph node. And I need to specifically target the thickened part of the lymph node. This is a lymph node that has complete obliteration of the hilum. On a theoretical basis, this could be necrotizing lymphadenitis, which is benign. But in those cases, there would almost always be clinical findings of infection or inflammation that are quite obvious. And in the patients that we would be scanning, they would mostly be asymptomatic. So this really is an indication of metastasis until proven otherwise, unless there are obvious signs of inflammation or infection. The final situation is loss of the lymph node capsule, irregular or angular or microlobulated margins. And this tends to indicate a lymph node with perinodal invasion. This is metastasis till proven otherwise. In all of these other instances, you could use FNA to prove that the thickened part of the cortex had metastasis. But in this case, you would specifically want to use core biopsy, and you would want to have part of your core involve the lymph node and part of your core involve the perinodal tissues to confirm not only that this is a metastatic node, but there is associated perinodal invasion. There is one last instance in which we would know that this is metastatic disease for certain, and that is a case where the primary lesion in the breast has microcalcifications and the lymph node also has microcalcifications. In that case, it's always going to be metastatic breast cancer until proven otherwise. I've seen maybe one or two cases of metastatic ovarian cancer to axillary lymph nodes that had a similar appearance. And of course, thyroid lymph nodes in the neck can have this appearance. But in the axilla, it's going to be metastatic breast cancer to proven otherwise, so we need to biopsy that lymph node. This just shows how we use the appearance of adjacent lymph nodes as a tiebreaker to help us distinguish reactive from metastatic lymph nodes. Here's a lymph node that has symmetrical cortical thickening. This is nonspecific. This could be due to a reactive node, or it could be due to a metastatic node, but the adjacent lymph node has a normal appearance. So the asymmetric involvement of two adjacent lymph nodes strongly favors this being a metastatic node. This is a more severe example. The hilum is completely obliterated in this lymph node. On a theoretical basis, this could be necrotizing lymphadenitis, but the adjacent lymph node is perfectly normal, and there's no evidence of inflammation, so this has to be metastasis to prevent otherwise. And this is another case where we have complete obliteration of the hilum and abnormal enlargement, abnormal hypoechogenicity, but the adjacent node is perfectly normal. This would never occur in reactive lymph nodes. This is virtually always going to be metastatic disease. So the simplest tiebreaker to use in cases that are nonspecific between reactive and metastatic nodes is simply to compare with adjacent lymph nodes. You can compare to the contralateral side. If you're unable to rotate your probe and find two lymph nodes in the same field of view, here we see a morphologically abnormal lymph node that's enlarged, has cortical thickening and obliteration of the hilum, and the contralateral lymph nodes are normal. Unless you have obvious signs of inflammation in the breast or arm, this is going to be metastatic disease and not reactive lymph nodes, because reactive lymph nodes are generally going to be some systemic etiology that causes them to be bilateral. Now, the histology of lymph node metastases is identical to that of the primary in at least 85% of cases, and theoretically I would think even more than that. What that means is if the primary lesion is hypervascular, you should expect the metastasis to be hypervascular. So this is the primary lesion with hypervascularity on color Doppler, and this is a metastatic lymph node that shows similar hypervascularity. If the primary lesion has high resistance, high peak systolic flows within the nodule, not in the surrounding tissues, but within the nodule, then you would expect similar flow within the metastasis. In fact, there is quite a difference in the waveform morphology between the pulse Doppler spectral waveforms in metastatic nodes and those of reactive nodes. This is a classical high resistance, high peak systolic pattern that we see with a lymph node metastasis. And this is a classical reactive lymph node appearance with a low rounded systolic peak and much lower impedance blood flow. Finally, you can actually look at the pattern of blood vessels on color or power Doppler. This is a small 7 millimeter lymph node that's just completely replaced with metastasis, showing again that size is a very poor criterion for whether a node is metastatic or not. This is the hilar vessel feeding this lymph node. Benign lymph nodes, reactive lymph nodes, and in some cases low-grade lymphomas tend to only be fed by hilar vessels that arborize to various degrees within the lymph node hilum, supplying the entire lymph node from the hilum. On the other hand, metastatic lesions often develop transcapsular feeding vessels because the metastases implant in the cortical or subcapsular sinusoids, and if they generate neovascularity, that neovascularity comes in through the periphery of the lymph node. So if you see a lymph node that contains transcapsular feeding vessels, that strongly favors it being a metastatic lesion or occasionally a high-grade lymphoma. If it just has hilar vessels that arborize to various degrees, as we see in this case, associated with symmetrical cortical thickening, that tends to favor a benign reactive node, or in a few cases maybe a low-grade lymphoma. This is a classical reactive lymph node, symmetrical cortical thickening, and a single arborizing hilar feeding vessel. And this is a classical metastasis. It's markedly hypoechoic, eccentrical cortical thickening with the hilum displaced out of the lymph node. It's abnormally rounded. It has not only a hilar feeding vessel, but it has transcapsular feeding vessels. This is just an example of how we work up our patients. This is a BI-RADS 5 lesion that turned out to be intermediate grade invasive ductal cancer. We performed core biopsy on this lymph node. We looked at the axillary lymph nodes, and there was a non-specific node that had symmetrical cortical thickening, but the lymph node immediately adjacent to it was normal. So our first tiebreaker said that this was more likely to be metastatic disease than a reactive node, and we perform a core biopsy on the lymph node, proving that it's a metastatic lymph node. You could perform an FNA on this lymph node as well, because we do not have evidence that there's perinodal invasion. Once we've decided that the lymph nodes are abnormal, at least that level 1 lymph nodes are abnormal, and we've decided that we're going to biopsy the lymph node, we always want to examine the lymph nodes at least one level higher than the definitively abnormal lymph node. The lymph node levels in the axilla are decided by the pectoralis muscle, which we can see transected right here. It would normally lie under this trapezoidal area. Lymph nodes that lie posterior to the pectoralis minor muscle are level 2 nodes. Lymph nodes that lie inferior and lateral to the lateral edge of the pectoralis minor are level 1 nodes. And lymph nodes that lie superior and medial to the medial border of the pectoralis minor muscles are level 3 or infraclavicular nodes. We always want to go one level higher than the nodes are positive. So if we see definitely abnormal level 1 nodes, we want to look at level 2 and Rotter nodes. If we have level 2 nodes, we want to go to level 3. If the level 3 nodes are abnormal, we want to look at the supraclavicular and jugular nodes. And in some cases, we will want to look at the internal mammary lymph nodes as well. This is just an illustration of an antiradial view in the axillary segment of the breast showing the pectoralis major muscle in front, the pectoralis minor muscle in back. Things posterior to the pectoralis minor muscle will be level 2 nodes, and things lying inferior and lateral to the lateral edge of the pectoralis minor muscle will be level 1 nodes. And notice that between the pectoralis minor and major muscles is a small lymph node that's a Rotter lymph node. In the strictest sense, these are not level 2 nodes. They're Rotter nodes, which are different, but they do lie at the same level as Rotter nodes. They can contain metastasis, and they can be a cause for local recurrence within the chest wall. Now here's an example of a patient in whom we did what I suggested. We saw abnormal level 1 nodes. We obtained an extended field of view to show the pectoralis major muscle in front, the pectoralis minor muscle behind. Remember that the lateral edge of the pectoralis minor muscle, shown by the right edge of this rectangle, determines level 1 versus level 2, so the level 1 node is inferior and lateral. The 2 nodes behind the pectoralis minor muscle are level 2 nodes, but the medial edge of the pectoralis muscle is shown by the left edge of the rectangle, and there is a lymph node that lies superior to it, and here's the clavicle. So this is a level 3 lymph node. So in this case, we have adenopathy involving levels 1, 2, and 3. And because this is positive, we do want to go above the clavicle and look at the jugular and supraclavicular nodes, and maybe even the posterior cervical nodes.